Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Okay, let's unpack this. Picture this. You're hit with a vestibular migraine attack. It's not just a headache.
Right, not at all.
The world is tilting, or you feel like you're on a rocky boat, completely unsteady. These episodes can be intense, frustrating, and just flat out disabling. They stop your day dead in its tracks.
Yeah.
So when that happens, when an attack is actively unfolding, what's your go-to move? I mean, lots of people, and doctors too, often reach for common migraine medications, specifically a type called a Triptan, hoping it'll just shut down the attack quickly.
And this is where things get tricky, because while triptans are, a mainstay for the headache part of migraine,
Right.
vestibular migraine is fundamentally about those really disruptive balance and dizziness symptoms. And for those specific symptoms, we've historically lacked clear, strong evidence for acute treatments.
Ones that are proven to work reliably and fast.
Exactly. Proven reliably and fast. It's been a real gap.
Right. A significant gap, especially when you think about how many people are affected. Our sources point out vestibular migraine impacts a substantial number of individuals. Estimates go up to nearly, 3% of the population?
Yeah, up to maybe 2.7%, something like that. And in clinics specializing in dizziness, it's one of the most common things they actually see.
Wow.
Despite being so common, the acute treatment strategies have often been borrowed from what works for headache migraine.
Or based on smaller studies?
Or based on smaller studies, exactly, that just weren't robust enough, statistically powerful enough to give a really definitive answer for the vestibular symptoms.
Which brings us to the heart of our deep dive today. We've been looking at a brand new, really rigorous study designed to tackle this exact question head on. Does a commonly used fast-acting triptan called Rizatriptan actually provide relief for acute vestibular migraine attacks?
Yeah, so our sources for this deep dive, there's a health news article covering the finding. And crucially, the full scientific paper detailing the study itself, published in JAMA Neurology.
Right, JAMA Neurology. So our mission is clear. Let's dive into these sources, cut through the noise, and really understand what this study found, what it means for treating these attacks right now, and where we might need to look next.
Okay, so to start, maybe just quickly reiterate what vestibular migraine is for anyone less familiar. It's distinct from regular migraine because the defining feature is these intense episodes of vestibular symptoms.
So balance symptoms.
Balance symptoms. Think of it as a disturbance in the brain's balance centers. This manifests as things like true spinning vertigo, or that feeling of being profoundly unsteady or just off balance.
It sounds absolutely miserable. And as you said, the current approach often involves just borrowing treatments from headache migraine. Precisely.
Triptans, they work by affecting serotonin receptors in the brain, which helps constrict blood vessels and block pain pathways, sort of the thinking behind headache migraine relief. And the hope was, maybe this mechanism might also calm down the brain activity causing the vestibular symptoms too.
Makes sense in theory.
But until now, the evidence for this specific use case, acute vestibular symptom relief, it's just been pretty weak.
Okay, so this new study aimed to fix that knowledge gap with a really high bar for evidence.
Yes, the purpose was quite straightforward. Rigorously test if Rizatriptan is effective and safe for stopping those acute vestibular migraine symptoms.
And they used a design that's considered like the gold standard in medical research, right? A randomized clinical trial.
That's right. Specifically, this was a double-blind, randomized, placebo-controlled study. So imagine participants were randomly assigned, basically flipping a coin, to get either the actual Rizatriptan or a dummy pill, a placebo.
Go.
And the double-blind part is critical.
Wow.
Neither the participant getting the pill nor the researchers giving it or evaluating the results knew who got which until the study was totally over.
So you remove the power of suggestion or bias for everyone involved.
Exactly. It's essential to prevent any bias or expectation from influencing the outcomes. And the study was done at two major centers specializing in neurology. That's doctors focused on the nervous system aspects of hearing and balance. At the Mayo Clinic and the University of California in Los Angeles.
And who were the participants? What kind of people were they looking for?
They enrolled adults aged between 18 and 65 who had a clear primary diagnosis of vestibular migraine based on very specific and strict diagnostic criteria.
So not just suspected cases?
No, they had to have a documented history of migraine and those significant episodic vestibular symptoms definite vestibular migraine.
How many people actually ended up in the study treatment phase?
So after screening a bunch of potential volunteers, 134 adults with active vestibular migraine entered the treatment phase, and they were asked to treat up to 3 separate attacks as they happened in real time.
And the treatment itself, what were they actually taking?
Participants were randomly assigned to get a single oral dose of Rizatriptan, 10 milligrams, or a matching placebo pill. They did assign them in a 2-to-1 ratio, meaning more people got the Rizatriptan than the placebo.
Why do they do that sometimes?
It's sometimes done to gather a bit more safety data on the active drug since more people are exposed to it.
Okay, so how did they measure if taking the pill actually worked during an attack?
Right, so participants were instructed to take their assigned study drug as soon as they felt a moderate or severe vestibular symptom coming on that intense vertigo or unsteadiness. This is key.
Okay.
They were targeting the balance symptoms first and foremost, not necessarily just headache, although they tracked that too.
Makes sense.
Then they had to rate the severity of various symptoms: vertigo, unsteadiness, dizziness, headache, sensitivity to light or sound, nausea on a scale from 0, meaning absent, to 3, meaning severe.
And they did this rating at specific times?
Yes, at specific time points after taking the pill, right away at 0 minutes, then 30 minutes, 1 hour, and then again at 2 hours, 4 hours, 24, and 48 hours.
So tracking everything pretty closely over 2 full days.
Yeah, very closely. And importantly, if their symptoms hadn't improved after 1 hour, they were allowed to use their usual rescue medications.
Oh, okay.
Though they couldn't use other triptans, obviously.
Right. So what was the main thing, the primary outcome they were looking for to call the treatment a success?
The main measure, the big question, was whether their moderate or severe vestibular symptoms, specifically the vertigo or the unsteadiness, dizziness, were reduced to absent or just mild within 1 hour of taking the study pill.
And why specifically 1 hour?
Well, because Rizatriptan is known to be a pretty fast-acting medication. It typically reaches its highest concentration in the bloodstream right around that 1 hour mark.
Okay.
So if it was going to provide rapid relief, you'd really expect to see it by then.
That makes perfect sense.
Yeah.
Did they look at other things too, secondary outcomes?
Oh, yeah, they looked at a bunch of other things, like did people get complete relief of vestibular symptoms at 1 hour? What about relief of headache and those associated symptoms like light sensitivity? How often did participants actually need to use those rescue meds?
Uh-huh.
And did the relief last? So symptom relief at 24 hours, and overall treatment satisfaction, quality of life impacts, and of course, any side effects.
Sounds like a really thorough approach.
Sure.
How many attacks did they end up analyzing in total for that main outcome?
In total, participants treated 307 attacks across the study. But for the primary analysis, that really crucial 1 hour outcome, they rigorously analyzed 240 attacks where the study drug was taken exactly as required when those vestibular symptoms were moderate or severe.
All right, so the moment of truth after all that careful setup. What did the study actually find? Did Rizatriptan stop those acute vestibular symptoms within that critical first hour?
Well, here's the key takeaway, the headline finding. At the 1 hour mark, Rizatriptan was not significantly better than the placebo at reducing moderate or severe vertigo or unsteadiness, dizziness symptoms down to mild or absent.
Wait, hold on. Not better. The actual drug didn't outperform the sugar pill for those core vestibular symptoms.
Incorrect. Looking specifically at the numbers for vertigo relief at 1 hour, about 48%, just under half of the attacks treated with Rizatriptan improved.
Okay.
But kind of remarkably, for those who got the placebo, the number was actually slightly higher, around 57%.
Oh.
Now, that difference wasn't large enough to be statistically meaningful. It could easily have just been random chance or just the natural waxing and waning of the attack itself, but certainly no benefit from the drug there.
Wow. That is genuinely surprising, especially given how often triptans are prescribed off-label for this. What about other symptoms of that 1 hour mark?
Headache, nausea. Similar story. Similar non-significant results were seen for headache and nausea symptoms at 1 hour as well. The drug just didn't show a clear, rapid benefit for those either compared to placebo.
Huh. So basically, no quick win for Rizatriptan in that first hour when you really need it.
Mm-hmm.
Did they see any effect if they looked later on, further out?
Yes, they did look further out at 24 hours. And there, Rizatriptan did show some, let's say, limited benefit compared to placebo.
Okay, like what?
For instance, In the group of attacks where participants managed without using any rescue medication,
Right.
they did see some reduction in unsteadiness, dizziness, and also motion sensitivity favoring Rizatriptan compared to placebo at that 24-hour point. And some additional analysis looking at all the treated attacks also suggested maybe some benefit for headache and light or sound sensitivity at 24 hours.
Okay, so some effect later on, but that's...
Yeah.
Well, it's nowhere near that rapid relief that someone suffering an acute DAC is desperate for.
Right. Exactly right. The main goal here was rapid symptom abatement, getting you functional quickly. And that's precisely where it didn't perform better than placebo. Those later smaller effects are interesting, but don't really meet the need for an acute treatment.
What about side effects? Was it safe to take?
Yeah, safety-wise, the findings were pretty reassuring, actually. There were no serious adverse effects reported in either group, rizatriptan or placebo.
That's good.
The most common side effects that were reported more often with rizatriptan were things like fatigue and feeling sleepy or drowsy.
Which are known side effects for triptans anyway.
Exactly. Those are pretty well-known side effects for this class of medication. And importantly, no participants had to drop out of the study because of side effects.
And how did the use of rescue medication compare between the groups after that first hour? Did the rizatriptan group need less?
No, actually. Participants in both the rizatriptan group and the placebo group ended up using rescue medications at similar rates after that initial 1-hour assessment period, which also kind of suggests that the rizatriptan wasn't providing sufficient relief early on to prevent people from needing to reach for something else later.
Okay, so let's try and put this all together then. What's the big picture takeaway from this really rigorous study regarding rizatriptan for acute vestibular migraine attacks?
Well, based on this trial, the key implication is, frankly, quite significant. Rizatriptan did not provide meaningful, rapid relief within that crucial first hour from the defining symptoms of vestibular migraine, the vertigo and the unsteadiness or dizziness.
Yeah.
While there were maybe some hints of later benefits for some symptoms, this study provides strong evidence that it's just not an effective, fast-acting treatment for the main problem in most people experiencing these attacks.
So the study author's conclusion must be pretty definitive based on these results.
It really is. They state quite clearly that the study findings do not support routine use of rizatriptan to treat vestibular migraine attacks. They were clear. It wasn't effective for any symptom at 1 hour, and they specifically highlighted it had no effect on vertigo at that critical time point.
This really makes you stop and think. If you, or perhaps someone you know listening, has been using triptans like rizatriptan for these acute vestibular attacks,
Yeah.
maybe based on older, less robust information or just clinical habit, what does this study suggest about that experience?
It strongly suggests that any quick relief you might have felt, particularly from the vestibular symptoms like dizziness or vertigo, well, it was likely due to a placebo effect, the power of expectation when taking a pill.
Right.
Or simply the natural course of the attack. Maybe it was just starting to get better on its own around that time, rather than the rizatriptan actively shutting down those specific symptoms quickly.
Okay. Now, like any study, this one must have had limitations, right? We should probably touch on those. Who do these findings most apply to?
Yes, absolutely. That's important context. The results are probably most directly relevant to patients similar to those in the study. So people seen in specialized settings like those neurology clinics where most participants were recruited.
Yeah.
How vestibular migraine presents or is managed might differ a bit in, say, a primary care setting, although the drug's biological effects should theoretically be consistent.
And they were very specific about the participants they included, the diagnostic criteria.
Exactly. They focused on individuals who met those strict criteria for definite vestibular migraine. This means the findings might not directly apply to people who have what's called probable vestibular migraine, which is a slightly broader, maybe less certain diagnostic category.
Right. And even with the best design, research can be challenging in practice.
Oh, absolutely. While they designed the study really well to be powerful, they still face some real-world challenges, like getting enough participants to treat the initial target number of attacks proved difficult. And also the fact that participants used rescue medications, while totally necessary for ethical reasons,
Of course.
it did reduce the statistical power for analyzing some of those later outcomes, specifically in the subgroup who didn't need rescue meds.
Got it. Okay. So given that rizatriptan doesn't appear to be the quick fix for those awful vestibular migraine symptoms,
Yeah.
where does research need to go next? What's the path forward?
Well, this study is actually really valuable even with a negative result because it provides strong evidence essentially ruling out one common acute treatment strategy for achieving rapid relief.
Right, clears the decks a bit.
Exactly. The main takeaway really is that the search for truly effective, fast-acting acute treatments specifically designed for those debilitating vestibular symptoms of migraine needs to seriously continue. We haven't found it yet with this approach.
So thinking forward, where should the scientific community be focusing its energy now? What kind of approaches?
Well, this really raises an important question maybe for you listening to consider too. Given these findings, what other types of medications or maybe therapeutic approaches might hold promise for providing timely, reliable relief from these vestibular migraine attacks?
Hmm.
Are there different biological pathways we should look at? Perhaps pathways more specific to the balance system itself, rather than just the headache pathways that triptans primarily target. That seems like a key area for future research.
Well, this deep dive into the sources certainly gives us a much clearer and I think more evidence-based understanding of whether one common acute treatment approach for vestibular migraine holds up to rigorous testing.
Mm-hmm.
And why, based on this specific study, it looks like it doesn't appear to be the rapid solution many were hoping for, at least for those primary vestibular symptoms.
Yeah, and understanding the evidence, even when it, challenges current practice or assumptions, is just crucial for moving towards better treatments and better outcomes.
Absolutely. Keep learning, stay curious, and definitely keep asking those critical questions about the science that impacts your health.
Indeed. Good advice.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.